Plastic and Reconstructive Surgery, Chapter 19. The primary goal is restoration of appearance or function to a particular body structure. There's, as the slide says, many systems and structures. Diagnostics are often done by visual examination of the surgeon. We also use some imaging studies, things that we've talked about many times: X-rays, MRI, and CT scans. Instrumentation is going to vary from institution to institution. All of these toys that the surgeons have are designed for themselves. So they're going to have little things that they really like. Some of them have a special scissors they like, or a retractor, or they all just kind of have their own little toys. The basic plastic instrumentation set is in your book on table 19.1. It's very basic. Same with the nasal set. The surgeons are certainly going to have their own stuff. Dermatomes are used to cut slices of skin for split thickness skin grafts. There are several types and brands available. Some are powered by electricity, some are powered by nitrogen. Make sure you secure the cord so it doesn't fall off of the sterile field. Each time you use one, you need to use a sterile disposable blade. Sometimes if you're taking multiple grafts, you're going to need more than one blade. They're like a fresh blade for each skin graft. There's a picture of a Zimmer dermatome. The other types of dermatomes are, as listed on the slide, the Ferris, Smith, Watson, and Weck are all handheld dermatomes that the surgeon controls the depth of the graft. The Paget and Reese are drum types. Again, the surgeon will control those, and the drum itself on the Paget and Reese is going to determine the size of the skin graft. More supplies would be a mesh graft device or a mesher, and the dermacarriers that go with it. The dermacarriers are what determines the expansion size of the skin graft when it's run through the mesher. So depending on the ratio of the carrier is going to depend how big the skin graft can get. Some other routine equipment may need a headrest. We're going to use head drapes, turban style drapes, like we've done in lab, and I've seen some of you do at the clinical sites. Also extremity drapes. When we work on hands and arms, we're going to do extremity draping just like we did in lab. There's the Paget Reese drum type of dermatome, and the Watson you can see is a handheld. It looks like an old razor that they used in the 1800s to shave people with. There's the mesher. I brought one out in lab and showed you guys, let you play with it, and only use a carrier once. If you use a carrier for a skin graft, you need to get a new carrier for the next graft. Skin graft sources, obviously from oneself, is autologous. Homografts are the same species, and as we've talked about many times, xenografts are from dissimilar species or animals. Two types of skin grafts are full thickness and split thickness. Full thickness, you go all the way through the dermis. Split thickness, we're only taking half of the dermis. Full thickness grafts are used mainly for covering lesions that are more than likely cancerous. They may be benign or metastatic, but they're smaller in nature, and we can use a full thickness skin graft for that. Split thickness grafts are used for larger amounts of coverage and are going to be used for big burns and things of that nature. Many factors determine the donor site, and as I said in class, a lot of it is surgeon preference. They have good luck using a certain site, but these other factors do play a role. Age and sex especially, and also the general health of the patient. The condition of the skin or the donor site is very important. So there are some of the common sites. I've also seen them take them off the gluteal areas. Skin and its responsibilities are listed on the slide. The layers of the epidermis, from innermost to outermost, are right there. I discussed them with you in class. That corneum layer is the outer layer where the skin sloughs off dry cells and regenerates. The layers of the dermis are the reticular and papillary layer. The subcutaneous layer is not part of the skin. Some accessory structures. Sebaceous glands are the glands that produce oil. That oil is called sebum. Sudoriferous glands are our sweat glands, and there are two types, merocrine and apocrine. We talked about those in class. And merocrines are all over your body. They secrete primarily water with a little bit of salt in it, and they are stimulated to produce sweat or perspiration, usually to control your temperature, but sometimes emotional stress also will trigger them. Your apocrine sweat glands are those that are in your external genitalia and your axilla. They are stimulated by pain. They become active at puberty, and they're also stimulated by emotional stress and sexual arousal. Ceruminous glands are that special type of gland that we talked about back in ENT that is in the ear, and it secretes a substance called cerumen, which is earwax. Burns can be caused by heat, radiation, chemicals, gases, electricity, and other means. The depth of a burn is classified according to degree, and there are 4 degrees of burn. As it says on the slide, the first degree affects just the epidermis and usually just causes some redness. It will not form a blister. That is a second degree burn. They're blister and they are painful, and they usually make it down to the dermis in some degree. Third degree burns completely penetrate the full thickness of the skin, and they become charred and pearly white. And this is what has to be debrided when we're going to do a skin graft. Fourth degree burns are char burns that go all the way through, and they're damaging blood vessels, nerves, muscles, and tendons. The abbreviated burn severity index criteria are listed up on the slide there. Those are the criteria for that index. The rule of nines is a measurement that we use to determine how much body surface area has been burnt. Patients with severe burns are going to need immediate therapy to stay alive. That's why you hear about some patients are flown by helicopter to a burn unit, because if they're not treated immediately, their chance of survival is almost none, depending on the severity of their burn. And they may need several procedures along with debridements to provide coverage of those burns and to restore their function and appearance. Again, most of plastic surgery, the diagnostic tests and procedures are going to be a history and physical and direct examination by the care provider. Some equipment we're going to need for skin grafts would be your dermatome and blades, your mesher carrier, some mineral oil, and some Hibiclens. Now, when we prep these patients for skin grafts, the donor site is prepped first and is considered clean. The recipient site is often considered dirty because it's an open wound or because it contains cancer cells. So you will need 2 setups of instrumentation in order to do this procedure properly. You need to at least change gloves during each portion. Some institutions, it's their policy to change everything. I like that policy. Also, when we take skin grafts and we've meshed them out and we're going to trim them, the surgeon is going to want a very sharp scissors, usually a tenotomy scissors, or they may have a special scissors that they like that we haven't talked about in class or lab, but it's going to be something sharp like a tenotomy scissors to cut that skin with. Scar revision is an aesthetic procedure, so a patient is going to want to improve their appearance and try to make the scar not so pronounced. Z-plasty is the type of revision that is most common. Again, diagnostic tests and procedures are going to be the same: history and physical, direct examination, basic plastic instrumentation. These are quick procedures, often done under local, but can be a general. Several types of scar revisions are used, but Z-plasties are the most frequently used technique. All those other ones are pretty uncommon. Head and face procedures. Congenital defects are generally caused in the first trimester, and people are very self-conscious of how their face looks, and they're going to want that to be fixed or improved. There are also some structural problems that can be fixed by plastics. But here's a list of the common procedures. Cleft lip repair. The most popular technique is the rotation advancement technique. Cleft palate repair is a palatoplasty. It's in a VY. A blepharoplasty is a surgical repair of the eyelid. We're going to take a elliptical incision above the eyelid, basically take that ellipse out and sew it back together. Dermochalasis or dermatochalasis is where your eyelid relaxes and becomes hypertrophic, and that is, like the slide says, linked to sun exposure and age. But often people have a hard time with their vision, and you need to correct it so they can actually read and see better. Usually a local or a MAC. We're working on a small area here, so suction is often a little too much or too big, and you will suck part of the eyelid up if you use a suction. So we have Weck cell spears, which are these little sponges that look like an arrow, and you dab the bleeder with the Weck cell spear while the surgeon is working to keep the field bloodless. Many times they will use a caliper to make sure that the eyelids look the same when they're done. You don't want one looking much different than the other. Endoscopic brow lift is a procedure where we're going to either ablate, avulse, resect, or separate the muscles so that we can bring that brow up. Again, diagnostic tests and procedures are going to be history and physical and direct examination. It's a fairly simple and quick procedure, and the instrumentation is up there on the slide. General or local with a MAC. And as the slide shows there are 3 general steps to an endoscopic brow lift. It's dissection, muscle elimination, or separation, and then we refixate so that it stays where it's supposed to. Malar augmentation is performed in patients with bone structure deficiencies. These can be due to trauma or previous facial surgical procedures. Again, the diagnostic tests and procedures are going to be history and physical, direct examination, and these they may want x-rays to pay attention to the zygomatic bones and the prominences in the cheeks. We're going to fix the cheeks. So this one can be a local with MAC. Make sure your implants and sizers are available and sterile before this procedure starts, so you're not into a situation with a patient already having an anesthetic and can't find the implants. This procedure is often done with a facelift or rhytidectomy. There's a little description of how it's done up on the slide. Mentoplasty is for cosmetic reasons. Micronathia, which is an underdeveloped jaw. You have a very small chin. So the one thing we have to pay attention to doing this procedure is the nerves on either side of the chin. We're going to make sure we don't mess those up. Again, diagnostic tests and procedures are history and physical with a direct examination. And these patients, like many of our facial patients, they often take photographs to evaluate the patient before and after surgery, and it gives the surgeon a good reference point of where they started from to have a photograph on the wall. These will be general or, again, local with a MAC. Supine position, Arms are usually tucked, sometimes Fowler's position for this procedure. And as that slide shows, there are two approaches. You can use an external approach or an intraoral where you go through the mouth. External is the most often used approach for this procedure. Otoplasty, there's a list of the anatomy on the slide. We talked about some of this in our ENT chapter. So often done for a congenital absence of part or all of the ear, and also you can have prominent ears that really protrude from the sides of the head, and that is due to an inadequate folding or absence of the antihelix. Once again, diagnostic tests and procedures are history and physical and direct examination, maybe some standard x-rays. For these, we often take costal cartilage out of the rib, so you're going to have some thoracotomy type instruments. Supine with the arms tucked, again either a general or a local with MAC. The goal in this procedure is to anatomically correct the ears or reconstruct them so they look natural to the contour of somebody's head. The ideal time to fix the ears in a patient is when they are young, ages 4 to 10. So as I said previously, you're going to be working with the ribs, getting that costal cartilage. So usually you'll have two setups, one for the primary procedure and the other to go get that costal cartilage. Rhinoplasty is a reshaping of the nose. Once again, history and physical, direct examination, standard x-rays. Nasal instrument set. This is a procedure where we're going to likely use cocaine. Make sure you dispose of the cocaine properly according to the institution's guidelines. Anesthesia will be a general or local with a little bit of mild sedation. These can be performed in the hospital, same-day surgery center, or even in a physician's office sometimes. It also can be an internal procedure that is done within the nasal cavity. Some surgeons really like to use a local anesthetic with a little bit of epinephrine in it to help with the hemostasis. And it also helps, remember, epinephrine is a vasoconstrictor. It'll help reduce the size of the nasal membranes. And of course, the big benefit of pain reduction post-operatively. This is a clean, not a sterile procedure. You'll need a separate setup. We talked about this in ENT for the anesthetic. Usually you have that all set up for the surgeon. He can just walk in, give the anesthetic part, and administer all the local anesthesia that he wants, and then your other setup is for the procedure itself. Rhytidectomy or facelift is a purely cosmetic procedure, and we're gonna get rid of that excess skin on the face and sometimes a little bit of subcutaneous tissue. The goal is to get rid of the wrinkles and folds in the skin. It's going to be supine with arms at sides. Local with a MAC is usually what happens, sometimes a general. These patients, our big concern here is to not get into the 7th cranial nerve. We don't want to damage cranial nerve number 7. And the way that happens is, like the slide shows, is with retractors. Somebody can be pulling too hard on a retractor, grab a retractor right against that nerve and stretch it. That can damage the nerve and cause all kinds of issues with the face. Post-operatively, we want to keep the head elevated, probably apply some cold compresses. This is common to all head and face procedures. Cleft lip repair. The rotation advancement technique is the preferred technique to fix a cleft lip. Anterior portion is the hard palate, posterior portion is the soft palate. Like I said earlier, the fetal development of the nose and mouth occurs during the first trimester. Cupid's bow is the middle curve, and we're going to use some fine absorbable suture for this procedure. So make sure you keep track of the small needles. These infants often have problems sucking or swallowing, and if they get into the age where they're going to start developing speech, they're going to have speech problems also. So we usually try to perform this procedure between 3 and 18 months of age, and the chyloplasty and palatoplasty are performed in combination. In other words, we're fixing the lip and the palate. There are the two methods that are common. The rotation advancement, as I've said, is more common. Again, a clean procedure, not a sterile procedure. This procedure, you may need your Dingman self-retaining mouth gag. And that is the end of the first half of our chapter. We will continue with the second part shortly.